Dear Dr. Prevenza, Dr. Shaw, thank you very much for having me, for the invitation. It's my pleasure and honor to drink from the source of the science. So I will speak about the options, the totally endovascular end options for the aortic arch, my disclosures. So the proximal treatment and sealing is not sufficient in at least 30% of the aortic dissection cases, and it's in most of the cases this is not enough to seal and to isolate the false lumen. So the false lumen increase and compression of the true lumen is one of the biggest predictors of mortality, and because of that, at least 15% of these patients will require a redo procedure. We know very well that the redo procedure, the redo surgical procedures are related to significant morbidity and mortality. So we have to speak in this case about endovascular options, minimally invasive options. Definitely when the landing zone is extended to zone 0, zone 1, this is the arch, we have to think about special techniques for cerebral vessels inflow provision. There are different hybrid, partially surgical approaches like shown several minutes ago. And endovascular advice is definitely both in the European Society and American College guidelines. But what about the availability of these branched and fenestrated grafts, custom-made grafts? For these possibilities, we need time. So it's quite difficult to do on an emergent case such a procedure. So in our proper aortic experience that is growing during the last years, we have in fact 3 totally endovascular, always available options. One of them can be large size aortic bare stent implantation across the supraortic vessels. The other one is the brachiocephalic vessels Chimneys assisted TEVR. And probably the newest one is the in-situ fenestration assisted intervention for such a situation in aortic dissection. This is one of the first compassionate implantations of a multi-flare flow modulation stent in a young 50 years old male patient in a critical aortic dissection condition with excellent 6 years result after the implantation with almost full resolution of the false lumen on the level of the ascending aorta and excellent flow distally for all the vessels. This is our experience with Chimney-assisted TEVR in 18 patients and with 10 patients with in-situ fenestration into the aortic arch for complex cases of aortic dissection. The immediate results were not related to mortality or switch to open surgery, and we had relatively good aorta-related mortality. I'm showing one of the cases that we have done by Chimney-assisted procedure that is definitely with good results into the trials and also in-situ fenestration, increasing the number of published cases. This is a 57-year-old male, like mentioned before, operated in the past. He was extremely symptomatic 6 months after the type A aortic dissection, proximal sealing and implantation and replacement of the aortic valve. With residual dissection type A, and in fact the dissection was not resolved. It's a continuing type A dissection involving the aortic ascending aorta and the brachiocephalic vessels. In this situation, totally endovascular, we puncture retrogradely the left carotid artery, and from the right axillary artery and from the left carotid artery, in fact, after the position of the parallel chimneys for the brachiocephalic and the left common carotid artery, we succeeded to centralize the flow with landing zone inside the surgical graft. So this is one of the cases with excellent centralization of the flow into the true lumen, practically full isolation of the false. What about in-situ fenestration? In most of the published series, in-situ fenestration requires heart-lung machine, so it requires brain perfusion. In this case is what about our in-situ fenestration protocol? We are doing with deep but conscious sedation without general anesthesia, and we make the so-called retrograde femorocarotid and femorobrachiocephalic vessel bypass following the natural gradient of the pressure, so without the pump. So this is the so-called homemade temporary extracorporeal arterial bypass flow that we are using. We are electrifying a wire, a very aggressive coronary wire with a connection to the electrocautery, and we are using or a Stato or Confianza Pro wire, very cutting the first 2 centimeters of the wires in order to be really aggressive. And this is the bypass. You see the travel of the blood from the femoral up to the brachiocephalic vessel. So this is the so-called natural retrograde following the gradient, the pressure gradient bypass, with about 60% 0.06 index of the pressure. And this is a case that I'm showing, again, the same scenario, a patient that was operated several months before the procedure with continuing dissection into the ascending aorta with a huge Euro score, so almost forbidden for surgery because of the high surgical risk. This is the implantation of the aortic graft, and you see all the catheters are already prepared, aiming to the aortic graft in several projections. We are checking, in fact, the orientation of the catheter, and this is the position of the lasso, of the snare, just below the tip of the catheter. And this is the moment of the crossing of the tissue of the graft with the electrified wire. And this is the snaring in order to provide true maneuver from femoral and from the carotid artery. And this is after serial predilation. This is the bridging stent graft, big graft implantation. And this is final result after making bridging stents in all the 3 brachiocephalic vessels with excellent flow, again with landing zone, proximal landing zone inside of the surgical graft, in fact done several months before this procedure. The clinical case evolution was really excellent. With that I'm finishing. Despite endovascular advances in fenestrated and branch devices, thoracic endovascular aortic repair for arch pathologies remains challenging. Parallel chimney, snorkel, and in-situ fenestration assisted total endovascular aortic arch repair is always available strategy. In-situ fenestration technique is evolving new strategy for complex high surgical risk patients with excellent peri-procedure and midterm results. We will see what will happen in the future and what will be the destiny of all these devices and these techniques. And thank you very much for your kind attention.